Good morning, and thank you so much for inviting me to cover a topic that is very close to my heart, which in this instance is about key breastfeeding needs and the role of the WIC food packages in supporting breastfeeding within your program. Breastfeeding is a very complex behavior that is determined by multiple layers of influence, ranging from federal and state policies to community and family support, all the way to access to qualified breastfeeding education and lactation management support. Based on this social ecological model that can be very nicely applied to breastfeeding that was developed by the CDC some years ago, at face value, it would appear as if WIC is only a small drop in the bucket among the myriad of factors that influence breastfeeding behaviors in the US. However, a closer look at the reality on the ground indicates that WIC has indeed become a major player influencing infant feeding choices at the national level. WIC serves over half of infants born in the US, and it's the only entity that comes closer to what, in my view, is a nationally coordinated breastfeeding promotion and support program. There is a very strong commitment to breastfeeding within the WIC program. And this is in part because WIC has a strong influence on and is influenced by major infant feeding stakeholders, including clinical partners, community partners, and the food industry. WIC is also a program that has a trust of local communities, has sound management and evaluation systems in place from the national to the local level, and it is considered by most a highly cost-effective public health program. A strong commitment to breastfeeding promotion and support by WIC is demonstrated by the development and ongoing improvement of the National Loving Support Campaign that is playing a central role building widespread capacity for breastfeeding promotion and support in the country. And this applies both within and outside the walls of WIC agencies. Currently, WIC has 5 endorsed key strategies to promote and support breastfeeding. These include paper and online education, peer counseling services, the ability for women to participate longer in the program if they choose to breastfeed, mothers receiving enhanced food packages as a result of their choice to fully breastfeed in relationship to the way the situation was before the enhanced food packages began to be implemented. And also, the WIC program has used the access to breast pumps as an endorsed strategy for the feeding of human milk to infants. Because the goal of this workshop is to zoom in into the food packages, I will first very briefly summarize, because Park has done a wonderful job already doing so, what is known about the impact of the WIC food packages per se, and then we'll move on to discuss what else may WIC be missing regarding the ability to better promote and support breastfeeding effectively. As already noted, the California study suggests that the introduction of the enhanced WIC food packages may have led to substantial increases in the selection of the full breastfeeding package. However, the increasing trend was already in place before the implementation of the revised packages took place, as clearly shown in these graphs. And this is very likely the result of the extensive and intensive breastfeeding training of WIC personnel and improvements in WIC participant education that took place prior to the introduction of these enhanced packages. For this reason, this very seminal study could not disentangle the impact of the WIC food packages per se vis-a-vis the improvement in breastfeeding outcomes that resulted because of the increased training and education that came before the packages were implemented. The national study commissioned by USDA that was led by Dr. Wildy also used a pre-post design and found decreases in the choice of the partial breastfeeding package, but that translated into an increased selection of both the full breastfeeding and the formula feeding package. In this study, there was no difference in breastfeeding initiation, pre and post implementation. Some have argued that perhaps the time span that elapsed before implementation happened in terms of the pre-data collection may have been too close to implementation, and maybe as it happened in California, there had already been other efforts in place that may have increased the rates of breastfeeding initiation by the time the packages were implemented. Nevertheless, something that Dr. Wildy didn't mention, but that it is important to do so, is that the study did find substantial increases in the choice of fully breastfeeding packages in the West region that were driven by the state of California, making those secondary findings very consistent with what Dr. Whaley and her team found in California. The most recent study by Joyce and colleagues using PRAMS, PENS, and NIS data comparing breastfeeding behaviors across time in WIC versus non-WIC moms did not find improvements in breastfeeding outcomes that could be attributed to the revised WIC food packages. And as it has been mentioned before, this study did document that in general there have been significant improvements in diverse breastfeeding outcomes in all the US population, including low-income women, but this simply cannot be attributed to the WIC food packages. So in summary, the evidence from what I consider to be the main studies in this area is that there is no evidence of impact of the WIC enhanced food packages per se on breastfeeding outcomes at the national level, although it looks like something very interesting has been cooking in California, and we must learn from that experience. And I think it is very interesting that that is an example that shows that perhaps the food packages per se may not do the job, but if the implementation is happening within the context of enhanced breastfeeding promotion and support, right and left across WIC staff and clients, then maybe the bundle or the whole package may end up making a difference. So the conclusion that the enhanced WIC food packages per se may not be having a significant impact at improving breastfeeding behaviors is not surprising, given the very extensive knowledge that we now have as to the complex multi-level systems approach that is needed to be able to move breastfeeding indicators to make breastfeeding work the way we want it. It is true to say that it does take a highly intersectoral village to make breastfeeding work. So I am not surprised that just the package enhancements per se would end up making a big difference. And a very relevant recent qualitative study conducted by Spencer Wambach and colleagues collected data from IBCLCs and peer counselors serving African American WIC moms, as well as from African American WIC moms that had been successful breastfeeding. And this study provides a very nice illustration as to why we shouldn't expect for the WIC food packages themselves, the enhanced packages themselves, to dramatically change breastfeeding outcomes. This very carefully conducted study clearly illustrates how breastfeeding choice ends up being the result of the intersection of multiple social determinants of health that have to do with very deeply rooted issues in our society, including oppression, stereotypes, lack of social support, and these are embedded in a society where breasts are simply perceived as sexual objects and where there is little tolerance for breastfeeding in public. The African American moms, all of which, as I mentioned, had successfully breastfed, were strong advocates for the need for breastfeeding peer counseling and mom-to-mom support groups. And I chose to present this study because it's a very high quality, qualitative study, but it really represents and speaks to a very large volume of literature that has been accumulating over the years. So speaking about breastfeeding peer counseling, I had the pleasure of co-editing with my colleague Dan Selen a special issue from the Journal of Human Lactation on the topic of breastfeeding equity. And as you can imagine, the topic of peer counseling really is in the minds of very high-level researchers around the country interested in improving the abysmal situation regarding exclusive breastfeeding duration, for example, among low-income women. The papers that addressed the peer counseling topic in this issue called to our attention the fact that WIC breastfeeding peer counselors are effective because they understand the social determinants of health and how they intersect with each other, in addition to the wonderful training, a lot of which is derived, by the way, from the Loving Support campaign that they are receiving on lactation management and so on. The message from this collection of papers are that WIC peer counselors are indeed central for bringing the issue of breastfeeding inequities to the central to a central position in the table of discussion. We also know through the paper by Rosga and colleagues that we published in this issue, and it is supported by a whole body of literature behind it, is that there is quite limited WIC funding currently in place to meet the demand the way it should be met for breastfeeding peer counseling services. And this is worrisome because we know that WIC has limited funds, but on the other hand, myself and other colleagues have conducted numerous randomized control trials showing how powerful, more intensive breastfeeding peer counseling programs can be that include face-to-face home visitation and more hands-on contact with the mothers. So low-intensity peer counseling models, many of which are the ones that are available nationwide in WIC agencies, may not be as effective as they need to be. And it was also brought to the attention the need to understand better how to triage and better allocate the limited resources for peer counseling that are being received at the state level, and how that triage can happen at the local levels. Also, the paper by Gross and colleagues indicates the importance of seriously considering using more social media as a tool to empower more peer counselors to deliver the services that they cannot do in person at the moment. So we know that the topic of infant formula is the elephant in the room when it comes to talk about breastfeeding and the WIC program. We know that it is an incredibly difficult and sometimes painful issue to have to address, but the reality is that it has to be addressed. It is very, very clearly established through the epidemiology of breastfeeding and breastfeeding interventions that women are extremely vulnerable to be nudged towards the introduction of formula when we're not preparing an even playing field for them. And we know that this is an issue that involves very heavily the food industry, the infant formula industry, marketing practices, and so on. So it is not myself, but others have suggested that perhaps one step the WIC program could take is to pay a little bit more attention to the protection of breastfeeding. The WIC talks a lot about promotion and support, and the word protection is almost a taboo because it immediately brings to the attention the need to really protect moms and babies against unethical marketing practices and making it very easy to go into formula and very difficult to go into breastfeeding. So one idea that has come up is for WIC to just use generic formula and pay full price and forget about the rebates and forget about allowing formula companies to use the WIC logo and to use the WIC name to associate this wonderful program with the sales of their products. There is also another idea that has been proposed by Jensen and Labok, which is similar to what has been done with the tobacco story, which is to require these companies that receive the sole source contracts every year to provide additional resources that should then be invested to promote and support breastfeeding. Others in the IOM workshop, loving support workshop that I chaired in 2011, are of the idea that perhaps we should also look at giving small incentives for each additional week of exclusive breastfeeding or each additional month of any breastfeeding. And these don't have to be very expensive incentives, but almost a reward for a stepwise approach to improving breastfeeding and exclusive breastfeeding duration. The Loving Support Workshop also concluded with a very strong consensus that it is really important to strengthen more the behavioral change aspects of social media and text messaging technologies to be able to capture that opportunity that it is widely available now to most WIC moms. And also it is important to embrace the social marketing framework that is based on the 4 famous P's that we really sometimes only focus on promotion and we forget about the price and the positioning and the placement of the breastfeeding as if it was a product. In terms of peer counseling, the epidemiology, the physiology of lactation, what it tells us is that it is absolutely crucial to reach out to moms through peer counseling, qualified services within the first 2 to 3 days after birth. That is a time when they are extremely vulnerable, when many of the lactation crises happen. We know that if moms are doing fine with human lactation within the first 2 weeks, it is very likely they may not need a lot of peer counseling services thereafter. Behavioral change, text messaging, and social media, using them as adjunct tools, obviously not to replace peer counselors, and to increase the ability of WIC nutritionists, peer counselors, and so on, to use motivational interviewing techniques and to receive very strong training on intersectionality and how to respect and take into account diversity and learn to communicate in a non-hierarchical manner. And at the end of the day, we have created expectations through the WIC breastfeeding peer counseling program. We are not coming close to meeting the demand, and I think this is an issue that needs to receive serious consideration, and it applies both to IBCLCs and the peer counselors they supervise. The 4 research needs, I'm going to summarize them briefly, are related to public perception of WIC, the WIC food packages themselves, breastfeeding peer counseling, and I think we need a new, good cost-effectiveness analysis of the WIC program that takes breastfeeding, promotion, protection, and support into account. I talked with a lot of people, clinic staff, administrators of WIC agencies, moms, etc., to try to understand what is their perception of the WIC program. And you get very different answers depending on whether you are looking at it from the inside or the outside. And I'm very confused. I don't know what the answer is. I don't know what any of you think it is, but it is very important. A public perception of a program is very important. Is it a breastfeeding program, a formula feeding program, or both? In terms of the WIC food packages, instead of thinking myself, I'm not an economist, in terms of how can we enhance the package, I would like to see research on how can we enhance the opportunity that the delivery or presentation of the packages offers for this to become a teachable moment, to nudge more moms into a full breastfeeding and much less into formula feeding. And the perception, again, of the WIC recipients about the monetary and non-monetary value of the different packages needs to be better researched. And at the end of the day, I think the very basic question is the choice of a food package reflected in actual infant feeding behaviors. It's a very important research question that, again, the California group has done some validation work that is really seminal and indicates that data, administrative data, are very promising. So in terms of breastfeeding peer counseling, I have gone through all these topics, but the third one I think is important and is the ones that my colleagues mention to me all the time, and is about why can the WIC program be expected to take all the burden on this? Why can't Medicare, why can't the Affordable Care Act contribute towards paying some of the IBCLC, PCs, breast pumping services, and so on? And last but not least, I think the cost effectiveness work that has been done before based on low birth weight prevention has been very, very heavily questioned in terms of its internal validity. I think we need to launch a new study to actually look at the cost effectiveness of WIC breastfeeding promotion, protection, and support from the perspectives of the WIC program, the healthcare system, and society at large. And I want to acknowledge these colleagues from Connecticut. Anything that I said that makes sense, it's because of them. Thank you very much.
Thank you. Thank you. Are there any clarification questions from the committee or consultants for Dr. Perez-Escamilla? No. Thank you. Then may I invite Virginia up to the podium?